So hello, welcome. Thank you for joining us for the Sight and Soundbites webinar today. My name is Carrie Fogel. I'm the Senior Director of Development for Foundation Relations for the Eye and Ear Foundation, and I'll be moderating today. We host these featured talks every month featuring different topics on vision loss, hearing loss, head and neck cancer, sinus allergy, vestibular disorders, and voice conditions. And today we're thrilled to have a topic in one of my favorite subjects, head and neck cancer survivorship. So our topic is titled Advancing Survivorship Care Through Research, and our speaker is Dr. Marci Nilsen. So quickly before I introduce Dr. Nilsen, I just want to remind the audience we aren't using the chat function today, but we will use the Q&A function down at the bottom of your screen. We do encourage you to ask questions through the Q&A box at any point during the talk if something interests you. And following Dr. Nilsen's talk, I will moderate the discussion and I'll ask her all of the questions that are presented during the program. We will make available a video recording of today's webinar on our website, the Eye and Ear Foundation website, following the conclusion. So allow me to introduce our speaker. Dr. Marci Lee Nilsen is an assistant professor at the University of Pittsburgh School of Nursing and Medicine. Dr. Nilsen co-founded and co-directs the UPMC Head and Neck Cancer Survivorship Clinic, which has been recognized for its interprofessional, patient-centered program that is designed to address the multifaceted needs of head and neck cancer survivors. Her research addresses treatment-related effects to improve the quality of life for survivors of head and neck cancer, and she also leads efforts in developing innovative care delivery models to ensure that cancer survivors have access to survivorship care of the highest quality. Dr. Nilsen is a graduate of the University of Pittsburgh School of Nursing. So with that, I think I'll turn it over to Marci Nilsen, and following her talk, I will be asking all the questions. So please share them with us at any point during the program. Thank you.
Thanks, Carrie. Thank you for having me. I took a little sneak peek at the attendee list, so I really appreciate all you coming, especially some of the patients who have just really allowed me to help in their survivorship journey and provide care. So as an introduction, so I am Marci Nilsen, and I am from the University of Pittsburgh, and I am a nurse. So my nurse is my background, and I'm a scientist. And so I think putting those two pieces together gives me a really holistic view on care, but also translates into a very patient-centered and hopefully thoughtful approach to my research and really helping patients focus on their quality of life and their preferences and how best to achieve those preferences and goals. And so you probably know about head and neck cancer, but if you don't, I'm just going to give you a couple little pieces of information because it will pertain to the rest of the talk. So head and neck cancer makes up about 4% of cancers in the US. It's about 7% or seventh most common cancer globally. It's more common in men. It's about 75, 25%, 25% female, 75% male. And that goes across the sites within the head and neck. And then many patients present with what we call local regional disease, or they have a tumor, which is in their oral cavity. So they're maybe your tongue or your tonsil or your voice box. And then you have lymph nodes that are positive in your neck for cancer. So it's spread to your neck. And so what that means is that most of our patients will get more than one treatment modality. And there is some variability, but generally it could mean surgery and radiation or chemo and radiation together. But most will end up having more than one treatment modality in order to try to cure them of their cancer. And for the most part, when I'm talking about head and neck cancer survivorship, I am talking about a collective term within the upper aerodigestive tract, but I do follow more of the National Cancer Institute's kind of definition of head and neck cancer, which doesn't include thyroid. So we're talking the mouth, the tonsil, the larynx, the voice box. Those would be the top 3 sites that we see in clinic, at least. We do see other sites, but that's going to make up most of the patients that do come to our clinic. And then this is important because human papillomavirus is anticipated to be about 30% increase by 2030. So many of the cancer patients that we see will have a cancer that's caused by human papillomavirus. And it impacts their care, and it also impacts their survivorship trajectory. And so most of the time we see this in the oral pharynx, so that would be your tonsil or your base of tongue. Incidence is on the rise, and patients are diagnosed younger. And so that's kind of the important part for survivorship. In addition to that, patients who have human papillomavirus associated cancers do also have a favorable outcome. And so these patients and these survivors are going to be diagnosed young, and they're going to live longer with the side effects of their cancer and their cancer treatment. So it's really making us think about different ways to not just treat them, but to provide care for them, both in the short and the long term, or in their more kind of permanent phase of survivorship. And when we look at head and neck cancer as a whole in the United States, almost about 500,000 people have been diagnosed with head and neck cancer or living with a diagnosis of head and neck cancer. So just to give, we always talk about how many are per year are diagnosed, and that's just generally how many are living with the diagnosis. They could be done treatment, they could be years out, but they still had a diagnosis at some point. And so what is exactly survivorship? And this is really a term that's been given by the oncology community. And there's been discussion of changing this word, and different survivors. Some survivors don't like the word survivorship because they feel that after their cancer treatment, they've continued to struggle, and it's been difficult. And so I do want to recognize that, and it's important. Some survivors have wanted to move to the word thrivership. Again, many patients don't always feel connected with that term, but we do use the term survivorship because that's kind of what's been recognized nationally. But what does it mean? So what is survivorship? So survivorship had previously been a term that we used for patients about 5 years out, or at least completed treatment. And that's really changed over time. And now we recognize survivorship and the focus of survivorship on the health and well-being of a person with cancer from the time of diagnosis to the end of their life. And so you are a survivor once you've been diagnosed with cancer, no matter at what point in your journey you are, if you're in treatment, if you're post-treatment, or in a more palliative treatment. Moreover, survivorship really goes beyond the physical side effects of cancer and cancer treatment. It should encompass your physical, your mental, your emotional, social, financial factors, and it should include things like follow-up, checkups, treatment-related effects, and quality of life. So it really is a holistic approach, a patient-centered approach that's multifactorial. The other tricky part about survivorship is it really goes beyond the survivor. It just goes, survivors come to their journey and their treatment with different experiences and with different lives. Some will have family members, some will have friends, some will have other forms of support that are recognized as caregivers, and we really should consider those in the survivorship experience. So as medical professionals, we're really set up well to deal with the survivor, and we're not set up as well to deal with the loved ones that come with the survivor. The focus of our medical record, the focus of our appointments are for the survivor, but we need to really start to get beyond that and understand that it is something experienced both by the survivor and their loved one. And so I will talk about survivorship from the time of diagnosis. And so how do we achieve survivorship care? So if you come here, we have one model, and if you go elsewhere, there will be another model. And so you don't need to know all these types of models just recognize that there really is not a standard approach to survivorship care, and there's not a standard model. And so we tend to have a model here that is multidisciplinary, and it is disease specific. And I'd say it's even on towards the integration, because we are within the head and neck surgery, so we are within the team. And what are the components of survivorship? So in the early 2000s, there was a task force that was brought together, the American Society of Clinical Oncology, and they really talked about what is essential for high quality survivorship care. And so after this symposium and this task force, they came up with essentially 4 pillars. There are pieces within this. And the focus at this point then also became what happens after you're done treatment. So when you're in treatment, you see your doctor maybe weekly, you see your medical oncologist maybe every 3 weeks, you see your head and neck surgeon regularly. And then as you get further out of your completion of treatment, you start having fewer and fewer close appointments with these providers. But you may still be having experiences and social or emotional or physical side effects of the treatment. And so many patients felt that they were lost at that point, and that it really created a lot of fear and anxiety and not understanding who to reach out to. And so within this component is a lot of focus on late and long-term effects and coordination of care. So we're tasked to do surveillance. So we're tasked to see if your cancer is gone, to see if there's any new cancers. We're tasked to encourage prevention, so smoking cessation, changing in lifestyle that may increase your risk for an additional cancer. There are subsets of patients that do have multiple cancers. And so really focusing on prevention and then management. So management gets to the surveillance, so watching for and managing of the physical, psychosocial effects. And then bringing in the team for care coordination. It's essential not just to manage things that are related to your treatment, but to manage any chronic conditions in partnership with your primary care provider, and also focus on health promotion and disease prevention generally, not just related to cancer. And so coordination with your primary care doctor, coordination with your oncology team, and any other providers that might be necessary. So those are generally the 4 components that survivorship program should hit. And now, when you're in treatment, you may experience nausea and vomiting, but what we want to watch for in the post-treatment effect is things called late and long-term treatment effects. And these long-term treatment effects start during treatment, and the late effects start after treatment. And so late effects can be hard. One, because we, for a long time, didn't have a lot of patients that were living for extensive periods with after their diagnosis. And now we have this larger population, mainly because of HPV. And so it's hard to sometimes distinguish what's related to your cancer, what's related to the treatment, what's related to aging. And so when I look at these lists, I would say it seems, and you might agree or disagree, depending on your experience and if you've had head and neck cancer. I felt initially that this was pretty comprehensive. It's by the American Cancer Society. It was geared towards primary care providers. But I'll say there are topics on here that I think are missing, cognitive function being one of them. And so I don't think that this list is comprehensive. And as we develop new treatments, there will all likely be new things that we can kind of add to the list. But one of the things you might note when you look at this list is that these treatment-related effects could cover a lot of different specialties. Hearing loss could be audiology. Shoulder dysfunction could be physical medicine and rehab or physical therapy. Dysphagia be speech language pathology. Fatigue could be broadly. So really, when looking at these national organizations, including the American Cancer Society, have put together guidelines that recommend that patients are treated with a team-based approach. Team-based approach being not just 3 different types of physicians, not just a medical oncologist, a radiation oncologist, and a surgeon, but going beyond that and bringing in other rehabilitation specialists, primary care doctors, dentists, nurses, speech language pathologists, social workers, dietitians, just to name a few, occupational therapy. So it really should be a team-based approach. To highlight what we do here at the head, so I didn't have a really fancy picture, so you got kind of all the casual pictures of the clinic. So we do, and in 2016, we initiated the UPMC Head and Neck Cancer Survivorship Clinic. How do patients get to us? It's a little bit unique compared to some of the ones across the country. So we do have patients that are identified both in our institution by our providers, but also by the community. And we do, which is unique for our programs, is we see patients at any point in the trajectory. Most survivorship programs see patients at post-treatment completion or at 2 years after treatment. We see them pre-treatment, post-treatment. Whenever you come to us, we will see you. And so once you get into the program, you do have a hearing screening. You fill out PROs or questionnaires. It helps us track how you're doing and compare to your last visit. Nursing assessment, physician examination, and then at that point, it's tailored. And if there's somebody that you need that's not in clinic, we refer. So what does it look like? So we have a surgeon or an APP, nursing, a hearing assistant, a speech language pathologist, a physical therapist, a dietitian, and a dentist. And it happens in one visit, in one clinical site, and one copay. And then at the end of the visit, we provide a survivorship care summary and we schedule follow-ups. And so one of the things I'll highlight before we really start to talk about the research that's come from what we do and some of the information that we found. So we'll talk about kind of what we've learned and where we're going from here. We do collect a lot of questions from patients, and it's really to provide patients the opportunity to tell us what they're experiencing, and then also to dive deeper into these questions. So literacy does impact outcomes. It's a social determinant of health. And so that's mainly for us as providers to be able to appropriately meet the needs and meet the conversation, the level that our patients need. Quality of life, the yellow one you probably cannot see, poor choice in colors, I'll say. Anxiety, depression, swallowing, neck pain, and limits in function, and sleep. And so a lot of these topics you'll see kind of woven throughout the presentation. So getting into the research and maybe the reason why you're here. So what have we learned? So what have we learned from the clinic? What have we learned from work that has stemmed from the clinic? So one of the things that I think is important for us to know as providers is what are some of the common issues that our patients experience. And so since 2016, we've had almost 5,000 visits, and that turns out to be about half of that is unique patients, about 2,000, 2,500 unique patients. And so when you take all the patients as a whole and look at what they report as issues that are important to them, and they affect their daily activities on a daily basis, this is current for them, we see, and they may not be surprising, that swallowing comes out on top. It's the most common issue that we deal with: taste, saliva, and pain. And so pain, I think, was surprising for me as a provider. I think it was surprising to, when we were working on publishing and presenting some data, it was surprising to others. And it's always remained in the top 5 since the start of clinic, even though we've changed our demographic a little bit. We went from patients more in the beginning, a lot of surgical patients, to having more non-surgical patients. Now, pain still persists. And so pain, because pain will go through the rest of the talk, just know that cancer pain is very common. It's estimated that depending on the time, 50 to 90% of patients with cancer will experience pain. Pain is one of the most feared symptoms related to cancer. So it's not only will I survive cancer, but will it hurt? And will I ever be without pain? Pain can last far past treatment. And there are many chronic kind of pain syndromes that can occur in patients who've been treated with cancer. Cancer pain impacts quality of life in a negative fashion, and others. And it's also a growing problem. And so one of the things that we saw and were very interested in the beginning of the clinic was patients' sensation and reporting of pain in the neck. And it was a common report. Many of the tools that we used at the time in the beginning did not ask about the neck, which is a bit surprising, especially I think we're head and neck cancer patients having surgery, especially in the neck. But it wasn't a common question, and we really wanted to delve into it more. And so again, it started from patients saying, "Oh, I'm getting cramps. You know, it's really stiff." The reporting varied. Some patients feel like they constantly have a collar on or a turtleneck that's on too tight. And then we'll talk about some of the other sequelae that come from this. But so what we call it is neck disability. So neck disability is pain that impacts survivors or patients' ability to conduct their everyday activities. Things like working, reading, sleeping, driving, concentration. How does this pain that patients experience in their neck impact those activities? And so we did have a subset. We always select for certain things. And so we looked at our patients, and surprisingly or unsurprisingly, this focused group, so these were patients that had to have a neck dissection, or you'll see the grouping of several different types of surgery, but they couldn't have had more than one cancer. We really kind of tried to make it related to just one cancer diagnosis. So half of these patients reported some degree of neck disability. And so most of them are in this mild to moderate group, but we do have patients that are really in a severe to complete group. So their functioning is very, very limited. And we also looked at certain types, treatment modalities. And so initially, we assumed that the more treatment you had, the more neck disability you might have. So surgery alone had the lowest probability of having neck disability. And then when you looked from surgery to non-surgical, so that'd be chemo or radiation, patients were statistically more likely to have neck disability. And then when you looked from surgery to surgery and adjuvant treatment, that probability continued to increase. So they were 4 times at greater risk. But when you looked at surgery, like chemoradiation to surgery and chemoradiation, there did not seem to be a difference. So much of this driver may be the fact that many of these patients are getting radiation. And radiation is something that continues to have effect on the skin and the tissue long after it's completed. And patients who have neck disability, even if it's mild to moderate, and that more, because that was the largest group making up the presence of neck disability, they have about 20 points lower physical and social emotional quality of life. And neck pain is not included in that measure of quality of life. So we know that the presence of neck pain can impact your function and your quality of life. So one of the other questions that we had is if you're having trouble moving your neck and you're having pain, which may cause you to not want to move your neck, what does that do to your swallowing? So there are better ways to swallow, better positions to swallow. And so how does that affect at least your swallowing symptoms? So this is subjective measures of swallowing. It's what patients report. It's what patients experience. It's not objective. It's not a swallow evaluation for anyone who's had one with a scope or a modified barium swallow. It's what patients experience and what they report. And so what we saw as the more neck pain you have, the more symptoms of difficulty swallowing you have. And so that increased as to the point where the people in the more moderate to complete group are having symptoms that generally start to correlate with objective changes in swallowing. We worry about things like aspiration. And so we really wanted to look at movement next. So we've kind of said now that patients do have neck pain, we see it, we can identify risk factors for it. We know the prevalence of how often it happens in our group. We know that these patients have other co-occurring symptoms that happen. But does pain in your neck really impact your movement? And with movement, one of the things that patients talk about a lot is, turning your head. So when you're driving, you want to turn your head. So that's the crux of this picture. And so we wanted to see not just the types of movement, does pain change the types of movement, but does pain change how fast you do those movements? Because you imagine if you know that you might experience pain, maybe you move slower, which can get into reaction. And so we had several of our survivors who participated, and we used some portable motion sensors, IMU units to the head and to the back, and we looked at rotation, so side to side, flexion and extension, up and down, and lateral bending as our planes. And then we looked at how fast they did it in terms of velocity. And so we also looked at pain scores. So this is pain scores, and you can see here the dots are what's significant. So when you looked at range of motion in terms of here, so there was significant changes in axial rotation with pain. So even mild pain. So we're talking, you can see here that the pain is really only a 2 to 4 on a scale. So this is going to change the side to side. And then velocity, it changed in actually all directions. So it changed in range of motion, it changed in axial bending and flexion and extension. And when we looked at neck disability related to it, we saw not as many significant changes in range of motion, but we did see changes in velocity, which does have impact on, function and how you carry out activities. But why? So why do survivors have pain? So I've already kind of hinted that we had thought that this was muscular changes. But when you present these findings and you talk to people, when you're radiated at the head and neck, they say, well, maybe this is not related to muscle. Maybe it's related to bone or cervical changes. And so we did do some work with CT scans, which you can see here. And essentially, this was done with Char Brain Center, who's our neuroradiologist. You can see the axial representation on one side and move my little box. So the axial rotation on A is an enhanced axial CT scan of a 56-year-old man with the level of the C3, which shows some atrophy in the sternocleidomastoid muscle, as compared to B, which shows some more changes towards the cervical spine. And so that is generally what we saw, is that patients did not have cervical changes to their spine that would attribute to, and so the disc is negative, so that is not, the more disc, the more cervical pain. So it's the opposite. So we did not see a connection between neck disability and neck pain and disc changes. So again, moving towards the thought or the idea that this is really related to musculoskeletal changes, tissue changes, skin changes. And so with all of that knowledge gained, so some of it came from clinical practice or stemmed from clinical practice, was obtained through the measures that we give patients and tracking patients. And then some of this was then separate pilot studies that we did. So bringing that all together, where do we go? Where do we go? What are the next steps? So one of the questions that you may ask is why? Why, or I ask, is why do some patients have more pain and more dysfunction and more fibrosis than others? And we do know that there are some treatment modality parts that connect: more radiation, more fibrosis, some more acute changes during radiation to the skin, longer, more likely with fibrosis in the end. But there's not a lot of information on the biological differences. So we know that even sometimes when patients seem to be treated very similarly and they can walk into two different rooms, these patients will look different. Their necks will look different. If I've taken care of you, or if you see me, I've likely pinched your neck. And so we're trying to get an idea of why somebody, their skin is elastic, their skin moves, their underlying muscle moves, and why are some patients experiencing symptoms which are really stiff, hard to pinch, can't move, and existing and having cramping. And so one of the things we looked at, or we're looking at right now, is microRNA. So microRNA are these little RNAs that are non-coding, but they really play a role in the regulation of your genes. And so these can sometimes be seen before. You can see changes in the deregulation of these microRNA before you have the tissue damage. And so in a pilot study, we looked and saw that these are just a lot of things that we looked at in a Go enrichment analysis, but we saw some uniquely differentiatedly expressed microRNA. And so in patients who tend to have more severe, these are in patients and in non-human primates, it was shown similarly. And so this is one of the next steps. One of the next steps is 2 ongoing studies that we have right now. One is funded by the National Cancer Institute. And so patients are enrolled pre-radiation. And we kind of accumulated all this knowledge. So we've put it into this study where we measure neck range of motion, we measure strength, we measure endurance, we measure swallowing, we measure fibrosis, and we measure symptoms, and we track them over time to see how these start to develop. And if there are certain groups that start to separate, can we then look at predictors of group membership? So can we then use all this data to see who is more likely to fall in a more severe group as opposed to somebody who only has mild symptoms, keeping in mind that we're looking at the changes in the microRNA over time. MicroRNA can be drug targetable, so there's a potential if we can identify a microRNA that has a target, that there may be ways to mitigate through pharmaceuticals, and then also through maybe more focused, tailored interventions of rehabilitation, prehabilitation, or exercises, which I'll talk about in a second. So this is going over 2 years. So this will be longitudinal. This started in the summer, or started actually in the fall. So recruitment is ongoing. The next study is also a longitudinal prospective study. And this is more looking at the microRNA panel specifically, the 4 microRNA. The other study will look at all microRNA. This will look at just the predictive value of 4 related to more acute symptoms of what we call fibrosis. So looking at xerostomia, trismus, and lymphedema. These lymphedema can co-occur with fibrosis. Trismus is the tightening of the mouth, so you can't open wide. And so this is a little bit of a shorter study, and it's really looking at prediction. And so even with these studies just beginning, we're still thinking about what's next, because Neither of these studies. These are really to describe the population, to identify the best timing to intervene and how to intervene, but they're not an intervention. And so how can we begin to have more focused interventions to mitigate fibrosis? And so we're in the process of looking at and working with colleagues in exercise oncology and in physical medicine and rehabilitation about prehabilitation intervention. So maybe focusing more in surgery patients. Prehabilitation is very common outside the United States. It's been shown to improve outcomes, even with a small dose within 2 weeks prior to having positive outcomes. Exercise, so exercise with a focus on some of the specific issues that we're seeing. We're doing more work to find out what exact muscles are being affected. So we always talk about the sternocleidomastoid, which is this big muscle in your neck, but are some of the more flexors and extensors and some of the smaller muscles also as important? Is it not just range of motion, but is it building their strength and endurance? So with that information, we really hope to focus an exercise intervention for these patients. And also considering focusing more on disability. So when we talk about physical therapy, is there anything else that we can add into physical therapy or disability focused interventions delivered by physical therapists to help? So anybody ready to lift these weights, let me know. You can be my test person. I'll join in with you, so I won't shy away. And then the timing. So timing is very important. In treatment, some studies have looked at moving during treatment. So balancing, is that possible during radiation treatment for head and neck? Patients experience a lot of symptoms, including weight loss and inability to eat. So what's the dosage and what's the amount that we can do during, or is timing is likely important. We probably need to do a better job of being proactive than we are reactive. And so you may say, well, Marci, you have talked a lot about physical changes. You have definitely hit how extensive the disability can be in the neck and how it can impact functioning. But when you mentioned survivorship, you mentioned it started from the beginning and it encompassed all of these types of things. So while you've hit the physical, you've really not talked a lot about the rest. And that will be true, though I've talked a little bit about how pain does impact quality of life. So hopefully if we can, we're working on not just neck pain, but oral pain and more neuropathic pain. So if we can impact pain, maybe we can improve the mental psychosocial outcomes. But one of the other things that we know, and I've mentioned, is that patients come to this journey and come to the diagnosis of cancer in a lot of different ways. And we know that social determinants of health impact outcomes for patients, all types of patients, not just cancer patients. And we talk a lot about in patient level factors like health literacy, income, education, marital status, race. But there are other things. So being in the blue, so neighborhood and built environment that can impact outcome. And so recently we looked at a metric called the Area of Deprivation Index. It is, does a patient's neighborhood socioeconomic condition, is it associated with symptom burden, psychological distress, quality of life? And so the Area of Deprivation Index really keeps, it's a metric based on sensor block data, and it really encompasses some theoretical domains. So it encompasses of the neighborhood. So income, education, employment, housing quality are just some of the domains that it covers. And we know that these more socioeconomically deprived areas can impact healthcare delivery for patients. And so with this catchment area, you may have surgery in Pittsburgh, but you may live in Erie or close to my hometown in central Pennsylvania, which may have different resources, not just at the cancer center you're treated in, but at the surrounding area that just may not be able to meet your needs that you have. So support for housing, support for food, community health workers, rehabilitation services. And so we wanted to see if that does impact our patients. And the answer is it does. So patients who are in the most affluent areas, when you compare the patients in the most affluent areas, survivors in the most deprived areas have lower physical, lower social quality of life. They have higher anxiety, they have higher depression, they have higher insomnia, and higher neck disability. And so I think while we talked about the 4 components of high quality survivorship care, an additional component is how do we make this high quality survivorship care accessible and equitable? And so how can we make programs and deliver care models in a way that meets the needs of the patients where they're at in an equitable fashion? And so part of the work we're doing now is really reaching out to community providers to see what their models of care are, to find out what some of the barriers and facilitators are to achieving or accessing some of these resources. But we've also started to talk about ways to proactively assess the social needs of our patients, social needs again being some transportation, and how can we integrate that in either to survivorship care that we provide initially, possibly as a first screening with a tailored approach, either with care coordination of a nurse or navigation, or is this something that we can just do broadly more in the group of head and neck cancer? And so it really, a patient's ability to achieve care and the care they need should not be dependent on their geographical location. It should be equitable and accessible to all. And so that is another of what we know and where we hope to go with the next steps. So not just touching the physical effects, which if we can deliver more high quality care and accessible care, we can achieve that, but we can also start to really meet the social and supportive needs of our patients. And so what I hope I've told you today is that survivors have complex physical and psychosocial needs. They stem from their cancer, from their treatment, and the sequelae from their treatment. There's an interplay of many factors. So social determinants of health, treatment and treatment characteristics, and biological predictors that affect symptoms and treatment-related effects. And we really only have a little bit of knowledge on some of these components, and we don't always capture them well. And so we really need to start to work towards delivering high quality, equitable care. We can start to test models through research in order to and partner with our community providers and really start to assess these social needs to achieve that. So I did want to thank everybody. So there's a lot of providers that have support the survivorship program, support many of the research that stems out of the survivorship program. We have an amazing clinical staff that we work with and research staff. And then always and forever, my survivors and the families that really allow us to help partner with their care and willing to participate in research.
Marci, thank you so much. That was a great overview of the clinic itself and some of the research that you have ongoing that you've collected since the time that the clinic started 8 years ago, which is hard to believe. So we do have several questions, and I think we'll have time to get through all of them. So if you are holding on to a question and you'd like to submit it for Dr. Nilsen to answer, please do so. We'll be able to get to it. One question that I had that I uh, wanted to ask is, you mentioned in the beginning that this is the survivorship clinic that we operate at UPMC through the Department of Otolaryngology is disease specific. And can you talk a little bit about the benefits of having a disease specific survivorship program as it relates to some of the other survivorship programs that people may see in other healthcare systems?
Yeah, so I think a lot of other healthcare systems have a more general approach because it's cost effective. They'll see more patients. But it's very hard to have one provider who can address all the needs of all cancer types. So obviously people who have breast cancer will have different effects than people who have head and neck cancer. And so having this disease specific approach really allowed us to bring the experts in head and neck cancer and in head and neck cancer symptom management and rehabilitation together. And so when you come to us, you know that, and you don't have to worry about whether or not this person has ever seen a head and neck cancer patient before, or has ever had the experience of knowing how to deal with dysphagia or swallowing trouble. And so that is, I think, one of the positives of having a disease specific approach is that we really can provide you expert care because we know all about head and neck cancer.
Great, thank you. We have a few questions related to accessing survivorship, the program, the clinic, the care, be it in rural locations or at regional UPMC sites. So I wonder if you could talk about the availability of the clinic and its services at other hospitals that are in more rural locations and also at other UPMC sites.
So many of our sites in the community do have some services just by nature of who's in their cancer center. So most of the community sites will have a dietitian. So that is something that you could potentially access close to home. There are sites with physical therapy. Again, that is sometimes hard because sometimes physical therapists in the community don't have a lot of experience with head and neck or head and neck associated issues like lymphedema. So that is an area that is a bit hard to just go straight into the community and try to provide care. You really would need to rely on your providers to kind of help you guide through that process. So the survivorship clinic that we run is only at Ioneer. However, if you say to me, Marci, I hate driving into Oakland, and I do hear that almost every Thursday, and I can feel it because parking in Oakland is unpleasant. The goal of Survivorship Clinic is that we have created some of these networks in the community. So if you come and see us on a Thursday, we don't want you to come in every week to Oakland. We will work with the community providers to identify the resources that you need. We have a network of physical therapists that we know treat head and neck. They get updates on treating head and neck, and they are certified in lymphedema. We know different sites that have speech language pathologists. We know some dentists in the community who have experience and or who are willing to work with our dentist on what to do for you. So generally, we like to see you in Oakland at least once, and then we will help you get back to your providers. And so just to make sure that everything, people are familiar with the condition, there are not coordinated programs currently like that in the community. But I'm always happy to answer questions. So if you wanted to see us, you can always email me. I help get appointments in for the clinic. And if it's really a struggle to get into Oakland, I can also try to problem solve with you and see what we can get you closer to home.
Great, thank you so much for answering that. Is there a wait time to enroll or be a part of the survivorship program?
No, the faster you email me, the faster you can get in. No, so there's not a wait time. So we don't, we try our very best to get you in as quickly as possible to clinic. And so we do only see people on Thursdays. So that is the one kind of downside is that we don't see patients on different days because of the number of providers. But there's not a wait time. You can come pre-diet treatment. I generally don't recommend patients coming mid-radiation because you're not going to feel great. If you do feel great, you can come see us. But if you don't feel great, coming about 4 weeks after you've completed radiation, by that point, you've started to feel like the symptoms are subsiding and you'll likely want to do more things like eating. That's a really great time to come visit us. So there's not generally a wait time. And we try to get you in as soon as we can.
Great, thank you. How do you integrate mental health providers in the head and neck population across the continuum of care, from the time of diagnosis moving forward, from the viewpoint of depression, but also with concerns surrounding mild cognitive impairment?
So that's a good question. And so previously we actually had a clinical psychologist in clinic with us. So that really allowed us to integrate and get patients seen quicker. And so generally what we do right now until something were to change, if there's a clinical psychologist out there that wants to come work with me, I'm all up for it. But right now what we do is a lot of screening. So if we screen for anxiety and depression, or we in the discussion with the patient that they're having some psychosocial distress, we do encourage patients to follow up with either providers at Hillman, or we have other providers who we can get patients to quickly. I run in partnership with Cancer Bridges, social support organization here in Pittsburgh. I run the head and neck cancer survivorship support group. So we provide those options. We also will refer, if patients have body image, there's a group that focuses on body image, and we'll send patients there. If patients complain of cognitive dysfunction, depending on their age, we will try to, again, refer potentially to clinical psychology, or to have neuro psych testing done with one of our colleagues, either at Benedum or through the Department of Neurosurgery and Neurology. So it really depends. And sometimes it's more than one conversation. So sometimes we start it, we follow up with it. And so there's not really a clear, easy path. But those are generally the steps we do. And if you know me, you know that this is, if it's whoever asked the question, but it's a big topic that I'm interested in and I've done research in. And I think it's something that we don't really have a great understanding in head and neck on. And sometimes it takes a couple conversations with our patients to get them to want to proceed. So it's that shared decision making and constant kind of communication.
So you talked about a little bit about some of the services that are available for patients who are in the survivorship program, who are going through treatment and surgery, support groups, mental health assistance, all of that. Are there any services available to the support network, the family members of the patients and the survivors?
Yes. So depending on the social needs of the patients and the caregivers, so we can work with you to try to find resources. The support group that we do, there are caregivers that participate in that. So that is one option. Hillman's Counseling and Services will also see patients and or caregivers and or patients and caregivers together. So those are some of the resources that, if in discussion with me or with one of our providers, if you raise those concerns, those are some of the things that we can try to activate on your behalf. and try to find sources for.
Great, thank you. We have time for one or two more questions. Someone has asked about insurance coverage for, being a part of the clinic. You mentioned in one of your slides, one visit, one copay. You also mentioned there was a dentist on your staff who sees patients. Can you kind of explain the structure of that?
Yes. So generally, the clinic is covered under your medical insurance. So if you come to clinic, you're going to, for the most part, get one bill. Now, if you have a special test on swallowing, you'll get a bill for swallowing. The initial dental evaluation done in clinic and the dental discussion just gets covered in that appointment. If you were to need subsequent dental cleanings, abstractions, if you were to need physical therapy ongoing, physical therapy would be covered by your insurance, and the dental portion would be covered by your dental insurance. Now, dental insurance is always something that can prove to be tricky. It's almost more like a discount plan. It doesn't always cover things. And sometimes you think, well, this is related to my cancer, so my medical insurance could cover it, but that doesn't work. And so some of those times we try to do our best job of seeing if you meet criteria for assistance, depending on your income, and other ways of trying to help if dental care is really a financial burden on you, and your dental insurance won't cover it, or you don't have dental insurance and your medical insurance won't cover it. So generally the clinic's covered. If you need additional things, that's covered by medical or dental. And if you don't have insurance or don't have a dental insurance, we do our best to try to find ways to get assistance for you.
Well, thank you so much. I want to be mindful of the time. We're coming up on 1 o'clock. I will just make a plug to say that if you are interested in rewatching this webinar or sharing it with anybody you know, it will be available on the Ioneer Foundation website in a day or two. And I want to thank Dr. Nilsen for all of your contributions to the field, to the department. Today is International Women's Day, so we are especially proud to have you as one of our great faculty to support. Again, my name is Carrie Fogel. If you have any questions regarding the webinars in general or anything for Dr. Nilsen, you can contact me through our website, and I'm happy to be a conduit to anyone that you may need. So with that, I think we'll go ahead and conclude. I want to say thank you again to Dr. Nilsen, and have a lovely afternoon, all of you.